Hi, everyone. Once again, my name is Spencer Dunleavy. I'm a recent graduate of Columbia Medical School in 2023 and currently in the Family Medicine Department at the University of Pennsylvania. Today, I want to talk to you about a little bit of my own original research quantifying progress or lack thereof in reducing health disparities in the last 20 years. So this analysis is entirely original. It actually mirrors analysis that unfortunately was published ahead of me by Caraballo and colleagues in JAMA in May of 2023. But I want to walk you through a scoping review of where we are in different health disparities across different diseases and conditions to give you a sense of the lack of progress we've had despite many medical advances. So the objectives of this conversation are to recognize the presence of modern health disparities and major causes of death in the United States, to critique progress in reducing health disparities by evaluating trends for the last 2 decades in both absolute and relative measures of mortality, and to identify areas where public health efforts should focus to reduce health inequity. So just to give you a sense of life expectancy trends from 2000 to 2019, and most of these analyses stop at 2020 because COVID dramatically affected health disparities, as we'll talk about. And you can see that the highest life expectancy tends to be in the Asian or Pacific Islander community up at the top. And then the white community tends to be pretty close to the average. Interestingly, Hispanic and Latino communities tend to have slightly higher life expectancy. And we have a guest lecturer to talk a little bit about that paradox in greater detail, so I'm not going to focus too much on it, but that's a very complicated picture. But what we really see is that the biggest health disparities in life expectancy are occurring in the Black and Native American populations in the United States. American Indian and Alaskan Natives have often 5 to 10 years less of life compared to the national or white averages. So in this original research, what I did was I went to the Center for Disease Control Prevention Wonder database. This is a database that collects death certificate data from all deaths that are logged in the United States. And when you log a death and fill out this death certificate, you have to list the causes of death and you identify a principal cause of death. And so this publicly available data set, which has been de-identified, allows public health researchers, policymakers, and clinicians to look at what issues are facing different communities by race, by age, by geography, rural versus urban, by county, by census tract, all these different things to identify where should we be targeting our resources and focusing our clinical and research endeavors. So I just want to, before I go into health disparities trends over the past 20 years, I just want to talk about a couple of pitfalls to be aware of. When we note disparities, we should be careful not to ascribe biological causes for these differences. As we had earlier in this course, the biological concept of race actually tends to harm patients more than it tends to help them. And so when we identify these differences, it's not because of differences between the groups, it's about the structural and social differences that have been imposed upon different marginalized groups. And so along those lines, we should be cognizant of the causes of health disparities. These are structural and they lead to worse access and quality of care for marginalized communities. There are some individual risk factors and behaviors that are important and they vary across groups, but these are much smaller contributors to health inequity compared to the structural forces of where you live, who you live around, and the wealth you have access to and things of that nature. Third pitfall to think about is we're only as good as our data. We can only talk about what we measure, and if our data is not accurate or comprehensive, we can perpetuate health inequity without knowing it. This is particularly interesting for death certificate data. When death certificates are classified, there's actually a race that's assigned to the person who dies. That tends to be assigned by if it's already self-reported by the person in like the electronic medical record, or a family member who identifies it in the process after someone has died. But if they don't know, then you could have the person who's performing the autopsy categorize that person. And what they found is when you look at characterization of race, specifically for Native and for Hispanic Latino populations, it tends to be done in a slightly inaccurate way, such that it underestimates the mortality for those communities. And so it's always something to be aware of, that if we don't have good data, we can't accurately tell the story that the data is trying to show us. And then finally, and perhaps the most importantly, when we measure health disparities, that's only the first step to addressing them. We need more than just awareness to make progress. Once we know the disparity exists, we need to start to actually address it. So there's some complexity about how we move forward with these trends in health disparities. Even if there are no disparities that we document in the community, we still need to prevent and treat these illnesses. And so even if there are no differences in, for example, COPD, we still need to focus on smoking and focus on tobacco cessation or harm reduction approaches to substance use. So just if I notice a trend that is not showing disparity, that doesn't mean it's not important. Second, this data that I'm going to present only gives a limited view of health inequity in the United States. Mortality and death is not the only experience of health. There's quality of life, there's satisfaction, there's other issues about how frequently cancers are incident, or how well we do screening, or how well we treat different things. And so there are different disparities with other outcomes I'm glossing over here. And the final point is that each community has challenges it's facing, and those require particular focus and investment to address. And so the other lecturers that you'll hear about in this unit are going to go into details for more detail for what sort of health conditions are showing particular areas of concern within each community. And this is just meant to be a broad scoping view over time for the last 20 years. So first, I just want to present some of the data for men ages 18 to 14. So these are the top 10 causes of death for men in this age group. And in all of these charts, the blue line corresponds to the Native American population. The black line corresponds to the white population, and that's to serve sort of as the reference category. The orange line refers to the Black community. The green line refers to the Hispanic and Latino community, and the gray line refers to the Asian American Pacific Islander community. And that's for every graph I'm about to show. On all of these major causes of death graphs, on the x-axis goes from 2000 to 2020, and the y-axis is the age-adjusted mortality per 100,000 people per year, essentially a measure of how frequently people die due to these causes. And so in young men, unintentional injury, suicide, homicide are the three major causes of death. And what you may not have known before today is that unintentional injury and suicide are one of the biggest causes of death, particularly in young Native American men. Unintentional injury is a huge problem in the Native American community around driving, around access to different substances, and it has a much more complicated history than I can get into here. But we see huge disparities for these outcomes. When you keep going, homicide is a large killer of the Black young men, young Black men, young Native American men, and young Hispanic men compared to the white population. And a lot of this has to do with how people are socially excluded from opportunity in their communities growing up. And then, as you are probably well aware, heart disease is overwhelmingly, it shows distinct disparities in the Black community. And so even in young men, we can already see that they're dying at almost 2 times the rate of heart disease. Cancers, we see an interesting trend. In the early 2000s, it was much more common for Black young men to die of cancer than white young men. And that gap has actually decreased a little bit. So that shows some progress. So you can look at all of these, you can pause the video. I just want to look at HIV very briefly. You can see that dying of HIV was, over 40 deaths per 100,000 per year in Black men in the early 2000s. And this has gone down dramatically in the 2020 and really emphasizes the role of primary care, prevention, and connection to access to care. However, despite that progress, it's still significantly higher than the white population, and so there's still a lot more work that needs to be done. When we look at women, we see similar trends, but we have different causes of death. So again, unintentional injury really affects predominantly the Native American community, but you can see differences in cancer, in heart disease, suicide, homicide. Liver disease also tends to be very much a concern in the Native American community. We're seeing high rates of liver disease and stage cirrhosis that are contributing to liver disease mortality. And a particular area that people are well aware of is disparities in maternal mortality or complicated pregnancy outcomes, where Black women are significantly more likely to die over time. Of interest, you may notice influenza and pneumonia. There's a spike in the 2008 era. This has to do with the swine flu epidemic or pandemic. And so that's why you see this jump in a lot of the graphs, but just to point it out. We look at middle-aged men, we start to see the patterns that you're probably most aware of. We see big gaps in heart disease, we see big gaps in cancer, unintentional injury, liver disease, diabetes, stroke. COPD or chronic lower respiratory disease tends to be fairly mixed. People use tobacco at sort of similar rates, and there's a very complicated picture there. So there's need in this area, but it appears a little different when you look at mortality. And then you can see other patterns here as well. In middle-aged women, we basically see similar trends. Cancer, though decreasing in overall mortality, tends to have this persistent gap in disparities in mortality between Black and white women ages 45 to 64. Heart disease, we see persistent gaps in these communities as well. Unintentional injury, again, in the Native American community tends to be much higher than other populations. We can again see liver disease is a big driver of mortality in the Native American community, even in this age group. And then stroke, sepsis, influenza, all of these things tend to be much worse outcomes, particularly for the Black and Native American communities in the United States. When we look at the over 65 age group, this is where we're getting the most deaths in the United States. You can see the scale of the y-axis changes from in the hundreds to in the thousands for the major causes of death. It's because a lot more people die when they get older. And this is where we really get a lot of the health, the contribution to excess mortality in the Black community. You can see the gap in heart disease for elderly Black men is largely stagnant since 2000. So though we're improving our management of heart disease, we're not reducing the initial gap that existed. In cancer, we've made some progress. Black men are still much more likely than white men to die of cancer, but that gap has shrunk a little bit. And we see the same trends in a lot of different issues, stroke or cerebrovascular disease, diabetes. There was a mistake, unfortunately, here that I forgot to correct about Parkinson's and Alzheimer's disease, but those actually tend to have fairly equal rates across groups. And this just gives a global sense of the absolute changes in mortality. But I think people think differently about mortality. They think about absolute trends, and they also think about relative trends. Oops, sorry, I got ahead of myself. Black women over the age of 65 show the same patterns. Heart disease has a persistent gap in absolute mortality across Black and white women. Cancer is downtrending, but still has this gap. But most of the diseases tend to have these patterns. Now, as I was saying before I got ahead of myself, we often think about mortality in absolute terms. This person, has a higher rate than this person, but really we care about the relative trends, because we want to know in 2000, maybe a Black person was, 5 times as likely to die, a middle-aged Black woman was 5 times as likely to die of nephritis compared to a white woman. How much more likely is she in 2020 to die of that same disease? And so looking at relative risk of mortality over time is a much more, communicable way to think about disparities in mortality across many diseases. And so these plots start to show that. So this is looking at just the Black population in the United States, only looking at the diseases where Black people tend to die at higher rates than white people in that disease. And so just to point out a couple trends. So for example, just to focus on one, in homicide, in 2000, a Black man aged 18 to 44 was about 13 times as likely to die of homicide. And that has been largely flat since then. So we're not making progress in reducing that. Moreover, if you look at these little symbols I've included on these charts, and I know they're hard to view in the video, but you can see if you are looking at the PowerPoint slides, that shows that the incidence or the rate of homicide is actually increasing in the Black community. So not only is the relative rate stable, that means that we're having more and more people die due to homicide. I don't want to focus so much on that trend. I'd like to identify areas of progress as well. So let's look at, for example, stroke. So in 2000, in middle-aged Black men, a Black man was about 3 to 3.5 times as likely to die of stroke compared to a white man. And over time, it is now down to about 2.5 times as likely. So we're seeing relative progress in the treatment of stroke. This is also coupled with a decreasing mortality risk. So this is when we see those absolute charts go down and have the gap decrease. So that's ultimately what we want to see. However, there are plenty of diseases where it's largely stagnant. And so you can see in the elderly community, the relative risk in Black men of stroke has actually gone up a little bit. You can see in heart disease for women, Black women over the age of 65, that also is pretty stagnant as well. So these relative risks can give you a sense of, are we making progress in reducing that gap for these communities? Looking at the Hispanic population, because there's this sort of paradox in mortality where the Hispanic population appears to have better life expectancy than the white population, there are fewer diseases that we can identify that have disparate outcomes. But there are a couple of interesting patterns to talk about. So it may look like we're making a lot of progress in Hispanic or Latino pregnancy-related mortality. So you can see in 2000, it was about 2.7 times as likely for a Hispanic woman to die in complications related to childbirth, and that now they're actually pretty much on par with the death rates for pregnant white women. And I might be like, this is really good progress. However, when you look at the incidence or the actual rate, the trends in rates of mortality for pregnant Hispanic women, you can see that it's actually going up. So when we see the equivalent relative rates in the setting of an increasing absolute rate in mortality, this means that just the white community is dying, or I don't like to say white community, the white population is dying at even faster and even higher rates than before. And so the progress in relative risks here is actually driven entirely by worse outcomes for pregnant white women, rather than improving outcomes in Hispanic pregnant women. And so we always need to keep these concepts of absolute and relative mortality in our heads at the same time. When you look at the Native American population, you see a lot of the patterns we see in the Black population with a particular focus on liver disease. So liver disease is overwhelmingly much more frequently affecting Native American men and women of most, especially young and middle-aged Native American men and women. And you can see that compared to a lot of diseases in the Black population where overall mortality has been decreasing, most of the diseases in the Native American population are having increasing rates of mortality. So liver disease is becoming more common, homicides is becoming more common, diabetes, suicide, unintentional injury, heart disease. And this spans across many age groups and multiple genders. And so this suggests that not only are Native American populations at continued elevated risk for many causes of death, but these situations may be getting worse. Which is a big red flag for us to think about treating this highly marginalized, largely from structural exclusions population. So in order to give a sort of summary of the lack of progress in treating health disparities in the United States, I wanted to borrow a methodology used a lot during COVID. This is called excess deaths. So it's essentially a measure of how many extra lives did we lose compared to what we expected in a similar scenario. So in COVID-19, this was, looking in March 2020 compared to March 2019, where they're largely the same except for one big difference, the COVID-19 and the shutdowns that ensued. Any deaths beyond what we saw in 2019 are likely to be explained by the COVID-19 pandemic and all of the policies that were put in place to restrict movement of peoples. And so by using your observed group, which in this case I say is mortality in the marginalized community, whether it's the Black community, Hispanic, Latino, or Native American population, that is my observed deaths. And what I expected was, well, if we had eliminated health disparities, they would have the same mortality as likely the white population, which is the largest reference group. I did not calculate and I did not report excess mortality in the AAPI community because they tend to have higher life expectancy and better survival for most diseases. Again, that's not to say they don't have health disparities they face. It's just a more complicated picture that I can present in this conversation. So I calculated excess deaths by looking at differences in the age-adjusted mortalities and then multiplying them by the population each year. And it gives you a sense of how many extra deaths we're having each year because of lack of progress in health disparities. So this is that plot. And so just like before, in orange, we can see this is the numbers for the Black community, in green is the Hispanic or Latino community, and in blue is the Native American community. So first, you can see the scales are significantly different across groups. Excess deaths in the Black community are far and away the biggest drivers of excess mortality in the United States. I'll go into the total numbers in a second, but it accounts for about 80% of all excess deaths in the United States, essentially quantifying how much health disparity costs us. 80% of those deaths occur in the Black community. When you look at the Hispanic and Native American community, again, the Hispanic and Latino community, although they have higher overall or better overall survival, higher life expectancy, when you look at disease-specific outcomes, they are still experiencing excess deaths beyond what we'd expect. And then again, as I highlighted, a particular concern is that Native American excess mortality persists and appears to be increasing at higher rates than other marginalized communities. And so it's a particularly important area we need to focus on as a clinical community, as researchers, and as policymakers. Now, you've often heard that the COVID-19 pandemic has reinforced and reopened health inequities across the United States, but there actually have been very few studies to look at this thus far because we haven't had the data cleaned yet. And so this is the first, one of the first ways we can measure this is, do we see excess mortality increase in these communities? And you can see from 2019, which is this corner right here, to 2020, there's suddenly these upticks in excess mortality across all of these major causes of death. And so these are showing widening of the health disparities in these communities. And these are statistically significant and confirm the results of some other studies showing that COVID-19 pandemic has really exacerbated the already existing health inequities that these communities were facing. So to give you a sense of what this looks like across all of these groups, so in total, from my calculations, and it slightly differs from the Caraballo calculations, but arrive at the similar result, is that from 2000 to 2020, about 1.5 million people have died from major causes of death in excess compared to the white population. What this suggests is that we are losing about 200 people every single day due to lack of progress in treating health disparities. When you look at where these health disparities fall, as I said earlier, about 80% of those deaths are affecting Black men and women, but there are still significant numbers of deaths that are affecting Hispanic men, Hispanic women, Native American men, and Native American women. So this chart allows you to look at how different communities are affected, but also shows you the area of clinical disease where you are seeing the biggest disparities. And so when we look at the overall excess mortality, heart disease is, as expected, one of the biggest areas where we might be able to reduce excess mortality. Diabetes is another huge contributor. Homicide, particularly driven by deaths in young communities, also is a large contributor. We see cancer is, of course, a big issue around excess mortality, and you can see the relative contributions of the other ones. And so this gives you a sense of, if we were to do public health or policy interventions to try to address different communities, each community has a different need. If we wanted to focus on 18 to 44-year-old marginalized populations, those interventions might be based more around structural opportunity and reducing gun violence, compared to policy interventions we might do for reducing stroke and heart disease in elderly populations. And so this just gives you a sense of where and how people are dying in these different communities. So I just want to quote one of the write-ups I did, and it will hopefully be included in a similar analysis I've done for disparities in child mortality and cancer mortality as well, Policy decisions that adversely affect and often intentionally target Black, Native American, Hispanic people have been key drivers in persistent health inequity in the United States. Racism is a structural cause of inequity in the first place, but racism may also be the reason for the slowness of response to addressing health inequity now that we are aware of it. And then I had to cut this line out from the manuscript because reviewers thought it was too charged. Put another way, would the situation be different if we could prevent 200 white people from dying every day? And what my argument here is that we are having 200 excess deaths every single day, which would be one of the top 10 causes of death. We're having these 200 excess deaths every day due to lack of progress in treating health disparities. If these were white people who were dying, everything would be directed towards solving this problem. But because these are affecting communities that have been excluded from representation, excluded from power, and intentionally fit into this white supremacist view, I believe that this lack of progress, this sort of flatlining of these relative disparities, is ultimately caused by racist views of how we should allocate resources. So if we want to stop the unnecessary loss of 200 Black and brown lives every day, we need to fundamentally reshape our society. We have to address the underlying structures that bring about injustice in the United States, namely wealth, income, housing, food security, education, and healthcare access. You often hear that that medical care only contributes about 20% of health outcomes, and the other 80% comes from structural causes. And that actually has been very well supported in the literature. They've even done analyses where they think about, well, what if we increased the educational attainment of different communities? How would that address health disparities compared to, treating more people with, surgery or medication? And overwhelmingly, improving people's education, improving access to housing, improving their wealth, improving how they can put food on the table is going to be the way that we can reduce these health disparities. So in conclusion, though overall mortality has decreased, health disparities in mortality have been virtually unchanged since 2000, with concerning signs that they've worsened since the start of the pandemic. Black and Native American populations have high absolute and relative rates of mortality compared to white populations for most major causes of death. And since 2000, over 1.5 million people have died due to lack of progress in reducing health disparities by mortality for these top causes of death. And so this is a very broad scoping review of where we are in health disparities, particularly with respect to mortality. And there's a lot more nuance to this conversation that needs to be had. And to go back to one of the pitfalls I discussed earlier, we're aware of this problem. These findings are not novel. Though they can get published in these big journals and cause a lot of alarm in the New York Times, we need to do something about them. We have solutions. They are largely structurally informed. And until we start bringing about those solutions, these inequities will continue to exist and get exacerbated when we have global catastrophes like the COVID-19 pandemic. So I hope you learned at least something from this lecture, and you'll learn a lot more from our wonderful guest lecturers who have talked about the particular needs of each of these communities in greater detail. Thank you very much.